We are good to start, sir.
Good evening, friends. Welcome to this Tuesday evening webinars from Yashoda Group of Hospitals from the Department of Critical Care Medicine and other specialties. We try to bring some topics of interest and current concern. And today, we felt that for the last couple of months, that may be 4 to 8 weeks, we have seen a surge in a seasonal fevers. The seasonal fevers varied from the lower respiratory tract and upper respiratory tract influenza and some of the COVID viral illnesses to a spectrum of other vector-borne viral illnesses, including the dengue and chikungunya. So there are cases which has been coming and referred to us in different spectrum, from a regular viral fever or a dengue fever with an NS1 or IgM positive. In the phase of recovery, there is a dip in thrombocytes, and that leading to a kind of concern in the family and the patients getting admitted for 2 days or 3 days. Once the platelet starts picking up, they go home. But there is another spectrum of cases who come in a sick state with dengue shock syndrome, with capillary leak, with multiple organ failures, with early warning signs, and leading to the fatality has been a concern over few decades in countries like India, where dengue has been a threat to us. If all of us remember, 2019, just the year before this COVID pandemic, there was a chaos with this dengue cases series. And particularly in these months, August, September, October of that particular year, 2019, where there was a surge of dengue cases leading to a lot of deaths, and many quality years were lost in 2019. And post-pandemic COVID-19, we have seen the viral cases being up and down in this monsoon season with increased breed for this mosquito vector. But this year has been a new challenge with, again, a mix of both influenza and a on and off rise of COVID-related ARDS and LRTIs. And this vector-borne, both chikungunya and dengue fevers being spurted in our ICUs. So we all understand about the dengue fever, which being a viral in origin, and the treatment modality mainly depends on the supportive care. We don't have a therapeutic treatment for a dengue fever to actually get controlled. We most of the times do a supportive care to most of these patients, and they do well. The current topic of interest which we are talking about is few of these cases comes with a fever which persists beyond 7 days. And that can be in the second week, most likely. And they say the patient has been having a fever till 5-6 days. There was some settlement of fever, but again, there was a second spike of fever in the day 7, day 9. And you generally see a leukopenia followed by thrombocytopenia, and then you see a recovery of leukocytes followed by a thrombocyte recovery. But if these patients persist to have a leukopenia, and you find the markers like your ferritin being high, and you also see that hepatosplenomegaly can be one phenomenon, and a hyperfibrinogenemia and high triglyceride and transaminase, LFT and RFT and coagulation derangement. These are all been not uncommon, which we see in these cases. So any patient who is having a dengue fever persisting beyond 7 days, we have a challenge of actually evaluating them for other causes of co-infections, secondary bacterial infections, and this so-called a macrophage activation syndrome, which generally, if you remember the COVID pandemic days, there was a lot of terminologies used. Patients landing into a cytokine storm, where a lot of interplay of cytokines causing a immune modulatory damage to the host, which can cause a catastrophic mortalities. So to bring this topic, we felt like we had a 2 to 3 cases in the last 2-3 weeks. And Dr. Dilshad, who is a fellow in the critical care department, and he done his post-graduation from Department of Anesthesia, and now she's in critical care medicine. So she will bring us few cases. Right now we have two cases also regarding what actually dengue HLH means. And from there, we will take you to two of our experts. Dr. Jitin is here, who is our rheumatologist in the Department of Rheumatology in Yashoda Hospital, Hitec City. So we welcome Dr. Jitin for your insights, and it's our honor to host you, Dr. Jitin. Thank you for accepting us. Please. And we have our hematologist, who is a seasoned clinician, Dr. Ganesh Jaishetwar. Dr. Ganesh, can you hear us? You can actually switch on your camera so that you can be a part of it. Dr. Ganesh is our hematologist. He's head of the hematology and bone marrow transplant unit. He has been a busy seasoned clinician who has been coming across with this dengue HLH as a common phenomenon in the last 2 months and before. So both of them, Dr. Jitin and Dr. Ganesh, will share their experience in the expert panel. So I will request all those audience delegates who are there can post their questions. So the biggest challenge which we are now facing is whether this is a dengue fever or this dengue fever with co-infections like any other viral co-infection, bacterial co-infections, or this is a persistent of a dengue hemorrhagic fever, or this has been in HLH. These or a bacterial infection has been predominated in this case. So to actually explore those all possibilities and how do we differentiate them, we will take the help of both these experts. So now I will request Dr. Dilshad to actually take us through the cases and to start the discussion rolling so that we can go into the discussion in the further. And I request all of you to post your questions in the chat box and question answer section so that we can take your questions. Over to you, Dr. Dilshad.
Good evening, everyone. So today the case discussion is dengue HLH. So the case one, 55-year-old female resident of Hyderabad came with a complaint of high-grade fever with chills, headache, and backache. 1-day history. She has a past history.
Pawan, are you there? Pawan or somebody from the technical team, they are there. We having a sound. No, the voice is not been clear. There is a disturbance. Is there two systems logged in?
It is there, sir. They're checking.
See, I think the same problem has been persistent in the previous one also. Whenever they are going to the PPTs, there is a noise. Is it with our problem? Dilshad, you can carry on. Okay.
So with the past history of type 2 diabetes mellitus and hypertension on regular medications.
Now it is clear.
Yeah.
On presentation, patient is conscious oriented, febrile with temperature of 103 degree Fahrenheit, tachycardic with 137 heart rate, normal blood pressure of 130 by 90, respiratory rate 24 per minute, and saturation of 98% on room air. So IV fluid and IV paracetamol started, and patient admitted to the room. On day one of all investigations, dengue NS1 came positive and malaria parasite negative with hemoglobin of 14.2, TLC 6,600 and platelet count of 136. The transaminases were in the range of 75 and 68, SGOT and SGPT with normal electrolytes. Patient developed shortness of breath and fever while transfusion of platelet and hence the patient was shifted to ICU, and at that time there was no signs of fluid overload and temperature was normal and IV fluid was continued. Repeat platelet count was 16,000. There was fever spiking continued. Patient became mild drowsy, sinus tachycardia remained, And 2D echo was done, which showed moderate LV dysfunction and global hypokinesia of the left ventricle. There was drop in urine output, and there was increase in acidosis, metabolic, and continued fluid. We continued with the fluid, and NIV was initiated. At this point of time, the TLC count was 4,600 and platelet dropped to 97,000. And further, in another 2 days, patient became more drowsy but arousable. Urine output dropped further, and acidosis was same. And at this point of time, patient was electively intubated, and the SGPT and SGOT was raised, which was like increased to 2,000 SGOT, and SGPT was 950, and the platelet count at this point was 10,000. Then vitamin K added, and medical gastro consultation done, and hepatitis serology was sent. Ultrasound abdomen showed grade 2 steatosis and with all signs of polysinusitis, and procalcitonin was 2.6. Scrub and lepto was ruled out with a negative report. Patient was having worsening sensorium and hemodynamic instability still, and with the worsening acidosis and increased lactate, and patient remained anuric, and CRRT was initiated, and IV antibiotic added. These were the ABG trends. Ferritin was done at this point of time, which showed 33,000, and the CRRT continued, and IV steroid was added as suggested by the hematologist, and plasmapheresis was done. Hemodynamically, patient improved with improving acidosis as well, and this was a trend, and which was continued for 3 days of plasmapheresis. Patient's hemodynamic stabilized, lactate was normal, and with but persisting thrombocytopenia, and there was ET bleed as well. Then as patient improved, CRRT stopped, urine output gradually improved, but ferritin still remained high to 13,480, and then patient was extubated on day 9. But there was persistent severe thrombocytopenia, and patient was in delirium. At this point, patient was shifted to the room, but there was new onset fever spiking, and then there was a rising trend of serum ferritin. LDH was high, and triglyceride was also increased, and patient was diagnosed with dengue triggered HLH, and with the final diagnosis of dengue triggered HLH, patient is still in our ICU, and treatment is going on. And this was the approach for the clinical management.
So actually, the cases which actually Dr. Dilshad is trying to bring a couple of cases which we are talking about, where there was one case overlap of initially we thought of dengue with multiple organ involvement, including a dengue acute liver failure with hepatitis and all. There was another case right now which actually referred to us yesterday from Gulbarga, where a young boy of 26 years, the IT professional who is working with some Microsoft company. So that guy was admitted with a dengue fever in the local hospital for last 7 days. And the patient continues to spike fever beyond 7 days to 8 days with almost 100, 300, 405 fever. And the platelets start dropping, and the leukopenia didn't actually improve. The leukopenia remained less than 1,000. And at that point of time, the clinician from the local hospital gave me a call asking me what are the possibilities in this case. As a standard care, we asked for a ultrasonography at that point, which suggested hepatosplenomegaly. And then when we asked for a ferritin, those were in initially with 3000, which is actually increasing in trend from 1000 to 3000. And enzymes are around 10 to 20 times elevated, and ultrasound showed hepatosplenomegaly. So this triggered us a possibility of a HLH in this patient. And we asked the patient's family to transfer here to see further evaluation. So this case is under us, and now follow up with the hematology team and critical care team here. So these are the cases which are not uncommon. This case is still under evaluation today only. The case is received and we are working. So to take this discussion forward, the initial discussion is, Dr. Jitin, few cases in dengue, whether they are NS1 positive or sometimes IgM positive, these patients, if the fever persists beyond 1 week to 10 days, so what are the differentials which should come to the mind of any clinician? What do you think?
Yes, thank you for that question, sir. So I think you gave a very good summary of the talk initially itself, and you had covered this point. So if in a patient with suspected dengue or proven dengue, after 5 to 7 days, usually fever should not go beyond 7 days. If it persists beyond 7 days, what we first think of is any superadded bacterial infection or a concomitant other viral infection, both of which can happen. So usually I would evaluate for either of these things, and sometimes these patients, once because of viral infection, they can be an immune disturbance, and they can be secondary pneumonia, etc. can happen. If that is not the case, if you have conclusively ruled out that it is unlikely to be a co-infection or a superadded bacterial infection, then yes, the chance of a dengue triggered cytokine storm, what we otherwise call as secondary HLH, is definitely would be my consideration. And we have seen it, like you also would have seen it, sir, as you yourself said, a lot of cases are coming now, and we have also seen it happen quite frequently. It's probably similar to, somewhat mechanistically similar to what we used to have in the COVID times. COVID also triggered cytokine storm kind of a picture. So definitely the underlying pathophysiology is more or less the same, but the end organ manifestations are also kind of similar. So I would consider these differentials along these lines only. Rarely, if they have received some antibiotics outside, some of these antibiotics can cause a febrile reaction, but they are usually temporary. Another thing is, if those RDPs, they would have might have received RDPs or something, then they can cause some febrile short-lived transfusion reaction, although they are quite uncommon with platelet transfusions, I believe. So
Dr.
that is
Ganesh,
what.
are you there? Some of the team members can just call Dr. Ganesh. He's there.
I think Dr.
He's
Ganesh has
asking to allow.
put on the chat to allow him into the
He's
webinar.
already in. I think he's also been trying to log in some other links.
So at 7:16, he's put in a message, please allow me in.
Sir, actually, I told Dr. Ganesh to raise his hand, so he might not get that.
You can
I've
call
called
him.
him.
You have his, please call
Yes, sir,
him.
I called
So
him.
in the meanwhile, Dr. Jatin, there is an interesting information which I actually happened to learn today.
Yes.
That is, even though this is not common in all the dengue patients, but when it comes to a very severe dengue patients, the percentage of the prevalence of HLH goes higher, and as higher to some of the reports says 15%, 13 to 15%. And in patients who actually could not be salvaged and lost life, in them when they evaluated, the HLH percentage was close to 40 to 45%, which is a scarily high.
Yes.
So I think it's more common when we are talking about more severe dengue,
True.
patients needing hospitalization, patient needing ICU care, compared to those who are in OPD based treatment, or those who are in only conservative supportive care at home or in the outpatient or in IP. But the sicker group of patients, the prevalence of HLH is not that uncommon, which we think, which is close to 14 to 15% in ICU patients. And those whom we lost, the percentage is as high as 45%. So Dr. Ganesh, welcome on board. It's always a privilege for us to host you. Thank you for joining.
My apologies, Dr. Venkat sir, because I was trying to log in from the. Anyways, so basically, what this case illustrates is the endemic infections like dengue, the severe dengue in particularly. See, the HLH is the spectrum of very severe dengue or dengue shock syndrome. The etiopathogenesis is same. So it's a heightened immune response, which is due to complex interplay of the altered immunobiology, the viral load, and other host factors. So many a times, as this case illustrates, it is very difficult to distinguish the very severe dengue like dengue shock syndrome versus HLH. But even in both the clinical scenarios, there are a lot of diversities and differences, but the management essentially revolves around the supportive care, maintaining the hemodynamics, and to dampen the cytokine storm, you need more intense immunosuppression in HLH compared to dengue shock, because dengue shock is just capillary leak and multi-organ failure, whereas in HLH it is a hyperinflammatory response leading to organ damage by cytokines, as well as the infiltration of the cytotoxic T lymphocytes as well as macrophages. So steroids, I will say, HLH is very, very underrepresented in severe dengue syndrome in our scenarios. If you see, the literature is very, very scarce, and most of us, the dengue spectrum of presentation, we emphasize only on dengue shock syndrome with persistent fever and end organ failures, and the HLH might be underrepresentation of what is quoted across the literature. That is what I feel, because in severe dengue, whenever you do these inflammatory markers, when the patient has cytopenia, either because of severe dengue shock syndrome or dengue hemorrhagic fever itself or HLH, but the persistent fever, persistent cytopenia, progressive organomegaly, and multi-organ failure is one thing which can give us a hint towards possible progression to HLH. And I will say practically a simple tool like serum ferritin should be done in all patients with severe dengue. And if ferritin is more than 10,000, it has a very high sensitivity as well as specificity for possible, dengue shock syndrome progressing to HLH. And this patient should be considered for aggressive immunosuppression with steroids plus or minus.
Ganesh sir, we will come to the treatment part. There are some interesting questions already in the chat box. So they are related to, even though we were only talking about today dengue HLH, so both Jitin and you are trying to emphasize, if I have a patient who has diagnosed to have a dengue with any form of either IgM or an NS1 initially with a clinical syndrome, but the fever persists beyond a week time. 1, 2, there is a drop in hemoglobin without a hemolysis and a blood loss. 3, you said a drop in cell lineage, either hemoglobin and thrombocytes or leukopenia and thrombocytes. So these gives a clue, and from there you said the basic test which we'll do is ferritin to start with, and probably triglyceride and fibrinogen later on. But there are other questions linked to, we said ki whenever the fever persists beyond a week, Jitan said it can be with co-infections. It most commonly with bacterial co-infection, which is not uncommon in severe dengue patients. And there can be viral co-infection. And more interestingly, one question came, there can be a tropical co-infection, so which can be a scrub, which can be a lepto. And most of the times we have seen enteric fever getting overlapped. And this enteric fever itself also can lead to HLH. So just to widen the discussion, what are the other infections which can actually cause a secondary HLH? Dr. Jitin, can you explain this, the secondary HLH from other infections?
So the other infections which can cause secondary HLH, I think the most one of the most talked about ones is Epstein-Barr virus, EBV infections. Again, a
Yes,
viral infection, one of the most common triggers for an HLH per se. The other infections we have, it has been well reported with TB. So once you, especially with TB, once you start treatment, there may be some host immune response that occurs, something like what happens when you start ART in patients with antiretroviral therapy in patients with HIV. There is a cytokine surge that occurs that can trigger. So TB HLH is well known. Apart from that, any viral in other influenza virus has been known to cause. COVID virus has been shown to cause HLH. For that matter, most of the viral infections, Coxsackie virus, enteroviruses, all these, not enterovirus, Coxsackie viruses, etc., definitely can cause HLH. Among the mycobacteria, it is tuberculosis. Bacterial infections per se can also cause, but it is kind of quite difficult to differentiate whether it is just a bacterial sepsis or a infection or a sepsis variant of HLH. But it is most commonly due with viral infections and sometimes with mycobacterial. Even with disseminated fungal infections, as especially in an immunocompromised setting, we have also come across like triggering a secondary HLH kind of phenomenon.
Dr. Ganesh, very specific question to you. The correlation with enteric fever, correlation with
And enteric
scrub and
fever also.
leptotyphus. So typhus. So because these are also the common fevers in this the season, the same monsoon season caters all these together. So the risk of HLH in any of these categories.
So, Venkat sir, this is a very pertinent and a common day-to-day challenge. Most of the times when we discuss the patients, particularly in the ICU under your leadership, the burning question is whether this is secondary, bacterial, viral, or tropical monsoon infection at the difference of dengue versus dengue progressing into HLH. So, there was a very nice seminal paper published just last year in Blood 2023. So we have started at our Yashoda Hospital, Hitec City, simple immunophenotype of T lymphocytes. It just takes about 8 to 10,000 rupees. Turnaround time is 6 to 8 hours. So the HLH T cell immunophenotype. So the CD8 positive cytotoxic T lymphocytes express very high level of HLA-DR and CD38. And this is very, very classic and characteristic of HLH. Probably most of the secondary and primary care centers will not have access to such immunophenotype, but many commercial labs are doing it. And in a patient with HLH, that is this T cell phenotype with these markers is 99% specific and 100% sensitive for HLH versus secondary bacterial sepsis. Now, coming to common clinical parameters distinguishing secondary bacterial sepsis versus dengue progressing into secondary HLH. So, the very high ferritin in constellation with low fibrinogen. Again, many of the primary and secondary care centers, fibrinogen level assay turnaround time is more than 24 hours. So a simple tool, do PT-APTT. If PT-APTT is more than 1.5 times normal, that suggests possible hypofibrinogenemia. So in bacterial sepsis, unless and until patient is in DIC, over the DIC, the PT-APTT will be high, but then ferritin will not be as high as in thousands. So ferritin more than 3000 has significance towards HLH, but ferritin more than 10,000 is very sensitive and specific for possible secondary HLH. So nowadays, most of us have access to smartphones, and you have this HLH probability score in all your calculators. It just takes 5 to 10 seconds to put all the patient related values, and you will get a HLH probability medium to high is again possibly secondary HLH. So, this distinction is very, very crucial because secondary HLH, uncontrolled, overwhelming immune response, if you don't treat it with aggressive immunosuppression, mostly say the secondary HLH, the most common immunosuppression we rely on is steroids, 10 mg per meter square of dexamethasone, or solumedrol 20 to 30 milligram per kg per day in children. So unless and until you resort to immunosuppression, the mortality is extremely high. It can be as high as 50 to 75%. Whereas in a patient with secondary bacterial sepsis or any secondary super infection, adding immunosuppression is going to kill the patient. So this distinction is crucial. So HLH probability score, ferritin particularly more than 3000. Again, ferritin is an acute phase reactant. It will be 500,000 up to 3000 in any reactive causes, but it won't be beyond 3000. And once the ferritin starts shooting above 3000, in constellation with raised PTA PTT, hypertriglyceridemia is and very high transaminitis again goes more in favor of HLH. But if you have access to simple immunophenotype of these activated T lymphocytes, it can be a crucial saver amidst these dicey situations, and which can make your diagnosis confident and which can make your therapy absolutely confident, because each therapy for these differentials can be detrimental to the other.
Dr. Ganesh, there is a question pertaining to this discussion. One of my very good friend, Dr. Srikant Sahasrabuddhe from Aurangabad, who leads intensive care in Medicover, has asked this question. So his question is like a ferritin is an acute phase reactant, as you said, like CRP or any of these D-dimers, which you do in any inflamed condition or a thrombogenic states, you may see this ferritin can come high. So when you do a ferritin, you give a quantitative possibilities that the higher the ferritin levels, more than 10,000, more than 3,000, can incline towards a possibility of HLH more than which when it is a lower than 3,000 in 500s or 1,000. That is one. Theoretically, he says any viral illness can actually causes this. So do you need a bone marrow aspiration or a biopsy when you have such a kind of dicey situation? You give some NK cell and the CD T lymphocytes mediated receptors and all that. But do bone marrow, see everywhere, as you said, the accessibility to those tests may not be available. A quick marrow aspiration, can it give a clue? That's a point.
That's a very important question again, sir. A very important pertinent point. Many of us believe that bone marrow showing hemophagocytosis, is again more in line with the diagnosis of HLH. But that, bone marrow not showing hemophagocytosis doesn't rule out HLH, because the bone marrow hemophagocytosis is seen only in 30 to 40% of the patients presenting with HLH at diagnosis. Of course, once you start doing the serial bone marrow, some point of time you will see hemophagocytosis, but bone marrow hemophagocytosis is not seen in 100% HLH cases. It is seen in only 30 to 40% patients at diagnosis. So bone marrow not showing hemophagocytosis doesn't rule out HLH. So of course, if bone marrow shows hemophagocytosis, it is a evidence supportive for secondary HLH, and your management can be directed in that line. Yes, it is a useful diagnostic tool, but its absent doesn't rule out HLH.
So there are another question: is it a diagnosis of exclusion? How we do in ITP?
The HLH from bone marrow?
No, suppose your bone marrow is positive, you're sure that it is 100% more likely you're dealing with an HLH. But
Yes.
if the bone marrow is not showing any engulfed macrophages, then you are still back to the same status. So when you rule out other possibilities, like you ruled out secondary bacterial infection, co-infections, other causes of fever, do you consider HLH as a possibility if you have a cytopenia, high ferritin?
So hyperferemia, ferritin more than 3000 with cytopenia, with splenomegaly goes more in favor of HLH if supported with raised PT and APTT. Whereas, the another important fact about the hypofibrinogenemia of HLH versus hypofibrinogenemia of sepsis related DIC. In HLH, the hypofibrinogenemia is over. Contrary to DIC, where, in DIC, you see oozing from all, IV, cannula site, all the mucosal surfaces. In HLH, that oozing is not that, clinically evident. The reason being, in HLH, the hypofibrinogenemia is because of these activated macrophages. They release a lot of tissue plasminogen activator, which leads to eventual release of plasmin, and this plasmin leads to hyperfibrinolysis. That's why the fibrinogen is low, and there is no actual overt bleeding unless and until you try any intervention in these patients. Whereas in DIC, it is consumptive coagulopathy, and the patients present with overt, bleeding because of this coagulopathy. That is one thing. The clinical picture supported with these simple biochemical parameters can help you distinguish HLH from secondary bacterial sepsis. Again, as I mentioned you earlier, ferritin being an acute phase reactant will be high irrespective of HLH versus bacterial sepsis, but the intensity of ferritin rise will decide. So, ferritin more than 3000, clinically deteriorating patient, cytopenia, and, many a times that HLH 2004 criteria, which we revert to, early HLH patient may not fit into the, classical HLH criteria. 5 out of 8 criteria must be fulfilled. That is difficult. But the cytopenia, increasing ferritin in constellation with low fibrinogen and organomegaly goes more in favor of HLH versus bacterial sepsis. Most of the bacterial sepsis, they are associated with leukocytosis rather than cytopenia.
So there was another interesting question, which is a day in and out burning concern for all of us. It is almost difficult sometimes to rule in or rule out a bacterial sepsis in this context when somebody comes with multi-organ failure and hemodynamic instabilities. But the other side, you have a possibility of a HLH in those situations, which with the procal being 2.6 and all. So how do you take a call on rule in, rule out a bacterial sepsis and manage this HLH possibility in them?
Sir, I would like to again highlight one more important thing here. Procalcitonin is not a specific marker of any underlying infection, be it bacterial or any infection. Particularly in a patient with a cytokine storm of HLH, procalcitonin is always high,
Yes.
right? So
Yes.
high procalcitonin doesn't rule out HLH, doesn't confirm bacterial sepsis. So if you are distinguishing bacterial sepsis versus HLH just on the basis of procalcitonin, you may end up in, erroring up with the bacterial sepsis and then missing the HLH. So, the clinical context with these biochemical parameters, the contrast biochemical parameters of extremely high ferritin with low fibrinogen goes more in favor of HLH. If supported with bone marrow showing hemophagocytosis, the diagnosis is almost certain.
Dr. Jitin, just to take you further, we also see that this bacterial sepsis can also lead to secondary HLH, which is not uncommon. Interestingly, we are trying to find out the difference between a bacterial sepsis and HLH, whereas sometimes one can lead to the other, which we have seen very commonly with enteric fever and all. So in many of those situations, when you have a dilemma, whether it is really to differentiate, sometimes it is not practically feasible or possible. In those scenarios, how do we go about? Actually, I have many situations like that when Dr. Ganesh or any of our other hematology colleagues were discussing with me. So the therapeutic options remained very straightforward and simple. So in those situations when I have still not ruled out, the therapeutic options, like you have a steroid, you have a etoposide, there were questions related to that. So how do you take decisions and what is the ideal choice in them, and which will you reserve?
Sir, if there is a really, as Dr. Ganesh very rightly pointed out, if there is leukopenia, it is more like very high ferritin and hypofibrinogenemia with leukopenia rather than leukocytosis. I would more tilt in favor of HLH rather than sepsis per se. Now, if there is still a confusion and we are not really sure, procalcitonin is somewhere mildly raised, which can very well happen in a cytokine storm per se. If that is the case, the one of the options which can very well be given and is safe from a point of view of sepsis is IVIG. So if that is not convincingly ruled out and the clinician is hesitant to use other immunomodulators like etoposide or steroids or any other stuff per se. However, if there is a reasonable surety that it is okay, it does not seem to be a bacterial sepsis. There are not like all the parameters favor that it is more likely to be the HLH version of the spectrum of the illness. Then we can go for again either steroid IVIG. But if there is a strong suspicion that the bacterial sepsis is not,
Dr. Ganesh, just kindly take that question on.
cytokine receptors on.
We are seeing Jitin's the internet connectivity has not been disturbing. So we'll come back to you, Jitin. Your internet connectivity has been little disturbance. So Dr. Ganesh, we understand that the steroids which we talk about, what is the dose? We even though we talk about a immunosuppressive dose, what is the dose which is recommended and what steroids are recommended? And then I will come back to the other IVIGs and plasma paresis roles in this.
So the most commonly recommended steroids for HLH cytokine storm is dexamethasone,
Yes.
10 milligram per meter square.
Oh.
Either you can give once daily dose or
Divided doses.
2 doses. But that is the commonest,
So that means if you come across 1.6 meter square area surface, which is ideal in between 1.5,
yes.
it will be 15 grams somewhere here and there. Is that you mean to say 10 to 15?
Yes. Yeah. So 15 to 16 milligram for adults. So we give 8 milligram BD dexamethasone. And as Dr. Jatin rightly mentioned, another potent therapeutic intervention in HLH of any etiology, whether primary or secondary, is IVIG. So the anti-idiotype antibodies in the IVIG, they block these immune dysregulatory cascade, and also they block the hyperactive cytotoxic T lymphocytes as well as the macrophages. So that's when you are in doubt and the patient can afford IVIG, 1 gram per kilogram per day, single dose, can be a vital life savior in a dicey situation where you are not sure about the differentiation between HLH versus sepsis. IVIG doesn't worsen the sepsis. In fact, it is anti-idiotype immunoglobulin. So it will be, on the contrary, beneficial. So under such dicey circumstances, 1 gram per kg single dose IVIG is preferable. The second point was, the role of etoposide. So for primary HLH versus secondary HLH, so secondary HLH is because either most of the infection triggered HLH or malignancy triggered HLH or uncontrolled autoimmune conditions triggered HLH, where most of our emphasis is to control the primary etiology, the supportive care for dengue, maintaining hemodynamics, trying to revert the dengue shock, and then steroids. Etoposide is one of the fastest acting therapeutic intervention for HLH. Even in secondary HLH, if patient is rapidly deteriorating, multi-organ failure, refractory shock, you can add 1 shot of etoposide, and it is most rapid acting because it immediately acts on the CTL as well as the uncontrolled histiocytes, and the response can be very, very robust and rapid. Of course, being a chemotherapeutic agent, most of the guidelines as well as the most of the international society recommendations are against etoposide for secondary HLH. But in a dire clinical circumstances, we have used etoposide with very promising and robust response onset. Now, coming back to steroid versus IVIG or combination. So depending upon the clinical severity, you can use steroid alone. In a dicey situation where you are not sure of the differentiation between HLH versus secondary sepsis, you can use IVIG. And when the patient condition demands, when the patient is rapidly deteriorating, quite sick, already with multi-organ failure, you can combine steroids along with IVIG. You can, both can augment the response of, in controlling the HLH cytokine storm in a much rapid way than each therapy alone. Venkat sir,
Kola sir, you're muted, sir.
muted, yes.
Ganesh sir, the discussion which we were doing related to the bacterial infection and steroid, which
Yes.
can actually counterproductive. But what we generally do in an intensive care unit, if somebody is in refractory shock, generally we replace a stress dose steroids, and that is equal to 200 to 300 milligrams over the 24 hours, either infusion or a 50 milligrams every 6th hour leading to 200 milligrams. That will be equivalent to 50 milligrams of methylprednisolone to equivalent of probably a 15 milligrams of dexamethasone. So what probably I will say, if I have a situation where I am doubtful, I'm not evident of either of them, the stress dose steroids in the form of any of them can be delivered till I get a confirmed diagnosis under the coverage of antimicrobial till the further. Because what we have been seeing, this key HLH can be detrimental if it is delayed in diagnosis and picking up also. So the dose which we are talking about, if it is in between the stress dose of septic shock or aseptic doses, still can be delivered, and which has suggested to not have any harmful side effects in at least in those situations. So that can be one more important point to actually bring. So there are interesting discussions related. You said the markers, either you say NK cell markers, or you said cytotoxic T cell mediated expression of some of these receptors. If those markers are negative, but you have a strong clinical context, what will you do, Jatin?
So the
The delegates and audience are more curious and I think having a lot of depth of this analysis.
yes. So these markers are basically, if the, the basis of HLH can make this understanding better. So, I'll just in 1 minute sum up the basic of HLH. What happens in HLH, this particularly in a very severe dengue fever with either hemorrhagic fever or shock. So there is immune dysregulation leading to disproportionate, viral infected target killing by these cytotoxic T lymphocytes and NK cells, which is a normal phenomenon. So what happens, because of this dysregulated killing, the more and more body tries to activate more and more cytotoxic T lymphocytes in an attempt to get the virus infection under control. And the more and more cytokines are released, which activates more and more macrophages. These macrophages release ferritin, and that's the reason why you get such thousands of levels of ferritin, because of the release from the macrophage, which are the storage site of this ferritin, right? And all this, the cytotoxic T lymphocytes and macrophage put together leads to this a profound uncontrolled cytokine release, and uncontrolled cytotoxic T lymphocyte activation lead to multi-organ dysfunction and these classical biochemical parameters of HLH. So going by that basic etiopathogenesis and analogy, in a lab with reasonable reliability, the sensitivity and specificity of this T cell phenotype, immunophenotype, is more than 95%. So this gives you a very confident diagnosis about possible HLH. But in places where you don't have access to such immediate, activated T cell immunophenotype, your clinical judgment of very high ferritin. So, that HLH criteria, 8 parameters. So cytopenias, more than 2 linear cytopenias, splenomegaly, persistent fever, very high ferritin, very high triglycerides, high LDH, transaminitis, and low fibrinogen. Of course, the other parameters, the soluble CD25 and IL-2, which is practically difficult to get in such a short period of time. But these biochemical parameters in combination with the patient's clinical presentation can give you an idea about possible HLH. And as you know, many a times, of course, I do understand many a times in a sick patient, the distinction between HLH versus other secondary infections is difficult. And under those circumstances, you can revert to IVIG, and as Dr. Venkat sir mentioned, the septic shock dose of, the septic shock bundle dose of steroids, which can really give you time to rescue and salvage these dying patients. But remember, your unattentiveness and your delay by whatever amount of time can be a trigger for further deterioration and very high fatality in these patients. Most of the time, the secondary HLH arising out of infections, you try to, again, dengue, there is no specific therapy for this dengue prodrome, but supportive care, and most of the times by day 8, day 9, the viral replication starts recovering, convalescing on its own. So, taking care of the patient hemodynamics, fluid management, supportive care aggressively, at the same time supplementing them with IVIG and the shock bundle dose of steroids. Most of the times, 24-48 hours, these patients will bounce back to recovery. So
Dr. Ganesh sir, just to continue the question answer session, to continue our discussion, we'll take these questions along with you, sir.
Yes.
There are questions from Dr. Saroj, who talks about multi-system inflammatory syndromes, which is commonly seen. So now we have seen the textbooks of medicine, including the Harrison textbooks, writes about the differentials of acute inflammatory conditions. You talk about adult stills, you talk about macrophage activation syndrome or HLH, you talk about multi-system inflammatory syndromes. So these are all categories which has been a part of now. So if we are talking about a multi-system inflammatory syndrome, how do you differentiate between a HLH with a multi-system inflammatory syndrome, particularly more so when it is in teenage group and children's in dengue?
I will say HLH is the extreme spectrum of multi-inflammation systemic, cytokine release syndrome. So this is the same spectrum, the HLH is the highest epitome of the same SIRS.
Okay.
So the treatment remains same, treating treat the underlying cause and try to dampen the inflammatory cascade, either with steroids. Nowadays, there are many, case reports of monoclonal antibodies. Post-COVID,
Yes.
we have become much
Yes.
wiser. IL-6 is rampantly available across most of the tertiary care centers. We have tocilizumab as IL-6 antibody. Of course, other, TNF-alpha, interferon gamma antibodies are also available across the globe, but not in our setup. And these are very, very promising, very rapidly acting, interventions, which sometimes we use even in our subset of patients, whether the primary root cause is severe sepsis with, multi-organ failure, with SIRS, you use those, antibodies along with steroids. So to cut the show, answer short, I will say HLH and SIRS are the same spectrum. HLH is the highest epitome of the same spectrum. Management remains the same.
Okay. The terminologies which has been used in these are cytokine storm, multi-system inflammatory syndromes, HLH, macrophage activation syndrome. There is one more actually question related to the low interferon gamma and vascular endothelial growth factors and VCAMs. If we follow these all for a diagnostic criteria for cytokine storm, which has been probably was a part of few papers which talks about the low interferon gamma, high IL-6, high growth factors, high VCAMs. So how do you actually see these cytokines giving you a diagnosis cytokine storm in dengue, leading to HLH. Dr. Jitin, you wanted to take that question. Any role of low interferon gamma with elevated growth factors and VCAM? You unmute yourself, unmute.
I am not aware of any particular role of these in dengue HLH per se, sir. Like, I am really not aware. I might have to go and check up on it. Like, and I don't think that these are routinely available for clinical practice. There may be translational science and some research papers which have shown, but their utility in routine clinical practice probably remains to be established as of now.
Dr.
Absolutely,
Ganesh,
sir. So,
it is
yes, sir. These
very-
are all, research
yes.
studies where they do this, but this all is related to the basic pathogenesis of HLH or any spectrum of severe dengue. It is applicable to dengue shock syndrome, it is applicable to dengue hemorrhagic fever, and it is applicable to secondary HLH arising out of severe dengue fever. So these are research molecules. Of course, the etiopathogenesis revolves around them. So, increase VEGF, these endothelial adhesion molecules attracting more and more of the cytotoxic T cells along with cytokines, leading to hampered vascular permeability and eventually leading to dengue shock syndrome. These are all research molecules. And as Dr. Jatin said, access to this kind of testing, and even if you have this testing, we don't have, in various disorders, of course, we have antibodies against these adhesion molecules also available for
Dr.
various
Dilshad, you can
treatment
stop
of
sharing.
hematological disorders. But
Dr. Dilshad, you can stop sharing so that we can have the full. Yeah, Dr. Ganesh, carry on.
yeah. So these are all research research setup, investigational tools, and they are applicable not just dengue related HLH, but dengue shock syndrome. The basic etiopathogenesis revolves around the increased vascular permeability because of these molecules.
So there are also questions related to whenever we talk about any inflammatory conditions, we talk about steroids followed by IVIG. More particularly when I actually talk about HLH or macrophage activation syndrome, steroids and etoposide comes. But IVIG, okay, as you placed in between when I wanted to play safe. But what is the role of plasma exchange? Does it has any role to play here? There are questions related to it.
I will say plasma exchange per se has, limited role in HLH as a whole. See, the basic, etiology lies around the macrophage activation, release of the cytokines, and which infiltrates various organs and causes organ damage. Even though theoretically plasma exchange as a tool to remove cytokines is, very intriguing, but it doesn't work. And there are not many, promising studies across primary as well as secondary HLH therapy literature with emphasis on plasma exchange. So I will say plasma exchange should be deferred. Immunosuppression with steroids plus or minus IVIG, and in very rapidly deteriorating, absolutely sick, dying patients, etoposide is life-saving rather than plasma exchange.
The role of some
If I may add to the plasma
please.
exchange discussion. So as sir rightly said, if we just see most of these, as we discussed in whether we call it SIRS or MISC or MISA, multisystem inflammatory syndrome in children and adults, or we call it HLH, or we call it MAS, the pathophysiology is the same. So if we look at evidence, if we look, the only available strong evidence for or against is from the COVID time. So during COVID, severe COVID-related cytokine storm, there have been trials of plasma exchange across the world. And if you look at the data, they have done a A meta-analysis of all these trials of plasma exchange in the COVID-related hyperimmune storm, and they have concluded that there was no significant difference in mortality or time to recovery in those severe patients when they received plasma exchange. So if we borrow evidence from that, considering that the pathophysiology is relatively same, I would that is one that we can just put across, that is the evidence that we can say that plasma exchange is not probably, although theoretically it should be, but practically it is not proven to be as useful in HLH based, although there are no specific indication wise evidences we can get. We can borrow it from the COVID era to just say that it's probably not the best tool available for this condition.
Dr. Ganesh, other questions are related to, can we use any filters like cytosol or a CRRT with some of
Absolutely,
those?
sir. That is another, very practical and very insightful question. So many of us, of course, there is not much of literature support for these kind of cytosorb or these, plasma filters. Of course, in overwhelming gram-negative septic shock, the endotoxin removal strategy through the cytosorb, or that endotoxin removal filters, or cytosorb in a patient with impending shock because of severe sepsis as a tool to remove cytokines. There is not much of a data of cytosorb or these toxin removal filters in HLH, and it has not been a common practice across. I'll also like to, another very intriguing comment, Dr. Venkat sir, with your permission, I'll quote.
Yeah.
Chat box, Dr. Just 1 minute. Dr. Sangam Yadav has quoted that, how do you confirm our diagnosis after IVIG if patient improves? Absolutely fantastic question, bacterial versus HLH. So the half-life of IVIG is 2 weeks, right? And if your patient improves after IVIG, you don't need to repeat IVIG. If patient is improving, you just take care of, supportive care for, the primary dengue infection. Most of the times patient will recover quite well. Whether it is bacterial sepsis or HLH, one shot of IVIG can really do a trick. Because the half-life of IVIG is 2 weeks. And if patient continues to recover, you don't need to repeat anything. But if patient continues to have persistent cytopenia, fever, then of course you have to, depending upon your clinical judgment, you might have to add steroid at this point of time.
So there are questions related again to the dosing of steroids. I think you have been very specific that 10 milligram per meter square feet area of body surface area. That comes around 16 milligrams. Ganesh sir, they just wanted to re-emphasize on the dose of steroids.
16 milligrams, 8 mg BD.
Yeah. So that probably correlates to the same stress dose of steroids which we use in septic shock. It's not the 1 gram of pulsing steroids, but it is still in the same, like 1 milligram per kg body weight of methylprednisolone to 10 milligrams per meter square feet area of body surface area.
So the one difference here is why the HLH, the data, the DEXA use of DEXA 10 mg per meter square is actually borrowed from the HLH trial. And the reason being that some patients with HLF can have CNS involvement also, even with secondary HLH. And as we all know that DEXA is the only among the steroid that has maximum CNS penetration. So if CNS involvement due to HLH is suspected, then rather than giving the stress dose, it would be better to give DEXA instead of hydrocortisone or methylprednisolone, whatever is being given.
So probably the last session questions related to this, we had a very insightful, thought-provoking discussion. COVID was a new pandemic to us, but it affected across the borders, so that we had so much of studies came up. There were so many platform studies came up, gave us so much of information, including steroids and tocilizumab, other tumor necrosis factor alpha inhibitors, and many. Do you both think that because the dengue is being limited to the countries like the low socioeconomic or those countries who are developing, with the load being more here, we still don't have the adequate research available, and we still can come out with some of those which happened in the COVID can also happen with dengue. Is that a possibility which is lagging in the developing countries? Or
I will like to, enumerate on this, sir, Venkat sir. So you might remember many of our cases in the transplant, bone marrow transplant scenario, who have recovered of transplant, who have a cytokine storm because of the neutrophil engraftment. Many times we have used tocilizumab as a, inflammatory, hyperinflammatory dampening short but very promising effective approach without any associated increase in the secondary infections or morbidity, mortality coming out of any other, secondary sepsis or secondary, the underlying infectious worsening. So analogous to the data which we have used in a short cohort of maybe 3-4 patients, we can definitely use, and the literature is evolving. So these, IL-6 antibody based on your IL-6 levels, tocilizumab, can be used in hemato-oncology, bone marrow transplant. We use it routinely for engraftment fevers, for patients with HLH, after engraftment, secondary HLH. This is being commonly used. And we have found in our short experience that it doesn't lead to heightened, the threat of excessive bacterial or fungal infection worsening has not happened. So analogous to that data, of course, as what you proposed is a very brilliant idea in a country like ours, where I'm sure most of the attendees today encountered severe dengue cases on a day-to-day basis, and a pilot project. And now post-COVID, the cost of tocilizumab before COVID used to be in lakhs. Now it is hardly 15,000-20,000. So it's a very vital, useful intervention, and we should take it as a pilot project to see how our patients respond. Not just dengue associated HLS, even dengue shock syndrome.
Okay, so I think that is a instigating question, research question to many of our viewers. I think we had a very insightful discussion over 1 hour, and we actually came to this, at least the summary, that all patients of dengue who actually exceed a fever span of more than a week associated with a drop in hemoglobin without a hemolysis or a massive blood loss, or a cell lineage which is dropping in numbers, not recovering after a week or 10 days time, you should consider sending a ferritin. The higher the ferritin, it gives more and more specificity towards a possibility of HLH. Other clinical criteria in a sonology, if you have an organomegaly, both hepatosplenomegaly gives an additional benefit. Hypofibrinogenemia, fibrinogen being utilized, can be another clue. And similar way, your triglyceridemia, the fasting triglycerides are high. This all adds to the bone marrow in a situation where you are in doubtful situation and you do a bone marrow, and the bone marrow gives you a confirmation with a macrophage engulfing cell, then probably you have a diagnosis, you clinched. But absence of a macrophage activation process in a marrow doesn't exclude, as Dr. Ganesh very clearly alluded, it can only happen in 40% of times, and it may not be there in 60% of time. So that can be a misleading. If you have an access, you can actually further evaluate to differentiate from the other common things in the form of NK cell variant or your markers of cytokines to actually give additional benefit to that. Even in doubt, if you rule out reasonably a bacterial infection, a protozoal infection, or an enteric fever or a viral infection, considering a steroid in a dose which has been mentioned, 10 milligram for a body square meter body surface area, which comes to 60 milligram twice, 8 milligrams twice a day, or a 16 milligrams once a day, should be considered, considering HLH being on card. And there are a lot of other therapeutic options which Dr. Ganesh discussed, including IVIG, and a possibility of other immunomodulators which should be considered if your primary therapy doesn't work. Etoposide, most of us agree that is not the primary drug when a patient is sick with a secondary HLH with a query of bacterial, viral, other infection. It is more confined to be a role which is played for a primary HLH. So probably this gives an insight that HLH should always be considered when this clinical context arises. And we had a very fruitful discussion, and we'll take two take-home points and then we'll conclude the session. Take-home point, Dr. Jitin.
Sir, you very well summarized the entire discussion. I don't think I have anything more to add. But as the take-home point would be to definitely keep our suspicion on, and especially in this particular season, for tropical fever-related HLH, whether it is dengue, leptospira, or enteric fever for that matter. And if suspected, we should consider starting immunosuppression or immunomodulation with either steroids or IVIG as already discussed, without much delay. So doing the mark in a suspected case, persisting fever, doing the appropriate biochemical tests and initiating treatment would be probably be game changing or life saving in these patients. That would be the take home message, sir.
Dr. Ganesh.
So, already Dr. Venkat sir and Dr. Jatin has highlighted all the pertinent, important take-home messages. I'll say in a, endemic setting like ours, fever persisting beyond 7 days, ferritin on a regular basis should be a common investigation in our chart, number one. Number two, fever beyond 7 days with or without cytopenia, with or without organomegaly, with or without clinical worsening, steroid should be in our mind, in our action. It doesn't harm, as Dr. Venkat sir mentioned. And if in doubt, IVIG should be a preferred intervention, because one HLH missed by a day can raise the mortality by many fold. And HLH is a medical emergency. Delay in diagnosis as well as delay in therapeutic intervention can lead to loss of many lives. We have become much and more smarter, particularly thanks to COVID has been a great teacher. And COVID related HLH, COVID related cytokine, our basic understanding about all these cytokine storms, inflammatory response, hyperinflammatory response has heightened. So utilizing our knowledge tools and being alert and being proactive in managing such serious complications can save many lives, in particularly in a setting where dengue or other viral prodromes are rampant, and the secondary HLH is probably underreported across the global literature compared to what we see in our practice.
Thank you, Ganesh sir. Thank you, Dr. Dilshad, in bringing that case. Thanking both of you for your presence and sharing your experience and knowledge and wisdom. And I thank all the participants for being with us. Thank you all. I conclude the session.
Thank you, sir.
Yes, sir.